All right. Well, good afternoon, everyone. Hope you're doing well. I guess it's afternoon if you're on the East Coast and morning in other places. But thank you for joining us for our Friday webinar. We have a very interesting topic that I think we got one of our biggest audience, biggest responses on this. Over 300 people are sort of tuning in to hear about this conversation. That's going to be led by our very own Gretchen Wartman. She's not a doctor, but she is a doctor, if you ever ask me. She's probably one of our biggest health equity expert at the organization. Any regulation she knows and she's dealt with. And so she's going to be a great facilitator for today's conversation. Before I turn it over to I conferred Dr. Gretchen Wartman. I just want to let you know that in April, we're going to have our National Annual Summit on Health Disparities. It's April 29th and 30th, where you can get to hear more in-depth conversations like the one that will be discussed today. And then we also have an application for our top 40 under 40 leaders in healthcare. The program started in 2016, and we've been doing it every year. So if you're interested, we'll put a link to both the summit and the 40 under 40 in the discussions tab. But without further ado, I will like to turn it over to Gretchen, who will lead today's program. Gretchen?
Thank you, Brandon. And good afternoon. As Brandon noted, my name is Gretchen Wartman. I am Vice President for Policy and Program of the National Minority Equality Forum. And in that role, I lead our Center for Public Policy. Our briefing today will focus on the escalating prevalence of state prescription drug affordability boards and their intersection with efforts to embed health equity as a tenet of the American Health Services research, delivery, and financing system. We are so pleased that three notable panelists are joining us today to share their knowledge and perspectives on these state prescription drug affordability boards, which are known as PDABs, with a particular focus on the degree to which PDABs can enable or hinder equitable access to efficacious therapies for Medicaid enrollees and for other population cohorts in the states that authorize PDABs. Our panelists are Dr. Desmond Banks, the inaugural Public Policy Research Institute Fellow at the National Black Caucus of State Legislators and a former social epidemiologist in the Centers for Disease Control and Prevention's Office of Health Equity. Mr. Jen Laws is our second panelist. Excuse me. He is President and Chief Executive Officer of the Community Access National Network, which is a national nonprofit organization that works to improve healthcare services and support for people living with HIV and AIDS. And our third panelist is Ms. Melissa Gong Mitchell, Executive Director of the Global Coalition on Aging, which is the leading business voice for aging policy and strategy. For our audience, throughout this briefing, please feel free to enter your questions into the Q&A box, the Q&A box, not the chat box. We will answer as many of your questions as possible during the Q&A session that follows completion of the opening remarks from all panelists. The first remarks will be offered by Mr. Jen Laws. Mr. Laws, please share with us your take on the state policy landscape and the potential impact of these PDABs.
Thank you so much. I want to take a second and say thank you to the National Minority Equality Forum for having this. It's an important topic, and I know y'all are working real hard. As a transgender man living with HIV, there are attacks on my access to care on the state level and on the federal level. And so kind of bringing up this issue of PDABs is quite interesting because on the surface, the goal of a PDAB is to make medications more accessible, more affordable across the spectrum. Unfortunately, the application in which we're seeing these PDABs move forward don't necessarily address the issues of access that are particularly concerning, especially for marginalized communities across the country and in those specific states. Now, PDABs are structured just a little bit differently from state to state, but they are modeled all after the same particular idea. that if you assess the quote affordability of a medication, you might be able to implement something called an upper payment limit or an upper reimbursement limit, saying a medication is only worth so much or only has so much value relative to the cost. So it's price. It's not necessarily price controls, but it's rate setting, for lack of a better term. And what happens in that situation is not, it doesn't, there's no mandate to directly translate that to patients or patient access. And there is no set of metrics. There's no requirements to monitor how this has any kind of impact on health equity, on marginalized community access to care, on network availability, any of those particular issues around access to care. And one of the things that I'd like to highlight to folks is that we talked about the difference between affordability and accessibility around COVID vaccines. For example, when they first came out and there was no charge associated with them, access was a meaningful issue that we saw. And we saw disproportionate negative impacts on access when we did not look at how to make sure that marginalized communities are centered and focused in these things. So that health equity piece is kind of really critical as to how we approach these things. The states that Community Access National Network is working in, we've been doing some work with Health HIV and the AIDS Institute as a coalition effort leading with HIV that is a health condition that is very highlighted in marginalized communities. So it's not limited to HIV, certainly, but it is where we lead with in that space. So we're looking at Oregon, Washington, Michigan, Illinois, Colorado, very, very specifically Colorado. A lot of states are referencing Colorado, Vermont, Virginia, Maryland. And then I believe that South Carolina just this morning introduced legislation, though we do not expect it to move forward there. Minnesota is on our list and Nebraska as well. This train is moving fast, moving on a lot of hypotheticals and with a lot of really good intention. I think it's really important to acknowledge that there's very good intention behind this. Unfortunately, the folks putting their hands in it don't have a good idea about how healthcare financing works, how the drug channel works, and how to meaningfully impact those things in a way that are tangible to patients, or how these things might impact those providers serving as safety net providers, particularly federally qualified health centers and hospitals accessing the 340B rebate systems. There are also public payers that we're particularly concerned with in terms of potential negative impacts, particularly in our space, the AIDS drug assistance programs. But Medicaid certainly would have some impacts on this as well. So what we've been working on doing is trying to kind of shed some light in that prospect. And we certainly appreciate the time today to be able to do so. So again, thank you for having us here.
Thank you, Mr. Laws. Ms. Mitchell, what are the Global Coalition on Aging's specific concerns about state prescription drug affordability boards?
Well, I'm going to build on what Jen has started with, but I first want to say thank you so much, Gretchen. Thank you, Brandon. Thank you to NMQF for hosting this very important and really timely webinar. As Jen was saying, really now is the time. Because, and for another reason, I mean, bringing awareness to this topic critically right now, we need to be doing that because PDABs, as the term, aren't yet topping our breakfast table conversations, nor is it an acronym that easily rolls off the tongue. So glad that we can sort of help bring more attention to that in our conversation today. I think I'm going to start kind of at a broader level in terms of how we at the Global Coalition on Aging think about these policy changes. So we bring in our perspectives of health equity through this lens of healthy aging, because we have this 21st century longevity. We do have longer lives now, and we should all have the same potential to grow older in society and to have the best quality of life as possible. And we don't see that across different communities around the United States. There are certainly health disparities. And the Global Coalition on Aging, we are a cross-sector group of companies that, from the pharmaceutical sector to the financial services sector to the technology sector to home care and transportation and others, that want to change this dialogue to recognize that we have this opportunity of our silver economy. So we have more older people in society than younger people. That does not have to be a bad thing, particularly if we have things like innovative medicines that are able to reach the patients who need them. And we do all this through convening global leaders. So conversations like this that build awareness, but also bring diverse perspectives to the conversation is really important. So as I said, we are really staunch advocates for innovation. And so that's what we created a group out of the Global Coalition on Aging called the Alliance for Health Innovation. And this group has more than 20 advocacy, research, patient groups, et cetera, across different disease areas, caregiving and other aging and others, to highlight this need for ongoing innovation if we are to achieve our healthiest aging possible. And again, we're representing patients, providers, caregivers, academia, et cetera. Because we're really at this important juncture in history of mankind. For the first time, we have more older people in society. We have our longevity, but we also have fewer younger people with lower birth rates happening everywhere around the world. And so we do need healthcare reforms. And it's not only for older people today, that's the kind of misnomer in us. It's not just for older people today, but it's because of this growing aging society that impacts all of us. So we have to get policies that are proposed like this right, not just for older people today, but for all the generations to come. So that is why it's so critical for us to be talking about this now. And when we think about how we were gifted our longevity in the 20th century, we got here because we innovated each step of the way through innovations in sanitation and refrigeration, new medicines that eliminated population destroying infectious diseases, new drugs and healthcare innovations really have changed seriously debilitating diseases, many of which increase in prevalence with age, and they've turned them into manageable chronic conditions. It's this miracle of the 21st century. And policies like this can threaten further innovation to get us to that next step to ensure that that we have a health span that matches our longer lifespans. And so we can't stop innovating now. This proposed policy really will threaten that. And so we don't want to take away incentives for innovators. And if we look at this through the overall equity lens, it's about ensuring everyone, regardless of your age, race, social economic status, has that potential to achieve healthy aging. And again, we recognize we have to make changes in our system. When Medicare and Medicaid were introduced in 1965, the average life expectancy teetered around 70. And so the system needed to support people for about 5 years. But now life expectancy is closer to 80 in the US, with the number of centenarians, as people living to 100 and beyond, having doubled over the past 20 years to about 90,000. And that's going to continue to increase. And so that, again, that's why we need reforms, but our goal should be to make sure people stay as healthy as possible for as long as possible so that we can prevent costly acute care incidents. We can limit visits to emergency departments and stays in the ICU and the hospital overall. So that's where the PDABs, when you're looking at upper payment limits and the potential to limit access, it may save payers in the short term, but we believe pharmacies and providers in many cases may be forced to respond by limiting access to these newer, often more expensive, innovative medicines if they're not adequately reimbursed. And such policies do typically lead to significant access restrictions. We've seen this in Europe and other countries around the world. And so it will disproportionately negatively affect the disadvantaged populations that the policies are meant to protect. And then again, through kind of our aging lens, many diseases that increase in prevalence with age, many of these drugs also, they're looking at some of the ones that are high in volume. So if that's, an anticoagulant to prevent an AFib attack, or a drug to strengthen bones to prevent an osteoporotic incident and serious disability from another fall, to vaccines, these are the exact ones that keep us healthier in society, that can keep us healthier, more active, more productive, more engaged, and not to be a cost, not to be an additional cost. So if we're looking at the overall impacts, we've got to think long-term, and we've got to see not only the benefits for individuals, their families, their caregivers, but also to the system and the overall cost. So I guess that kind of sums up a little bit in terms of how we are thinking about this. We don't want to stifle innovation. We want to make sure the individual stays at the center of how we look at these policies.
sorry, I was muted. Dr. Banks, in your view, can a focus on health equity and state prescription drug affordability boards coexist, or are there inherent unresolvable conflicts? The floor is
Wow.
yours.
That's a powerful question, Ms. Wartman. Thank you very much for asking. Just want to pay attention to the chat. There's a question, would anyone repeat what the acronyms PDABs means? And that stands for Prescription Drug Advisory Board. So just want to do some level setting on that end. Before I dive into the answer on that question, Ms. Wartman, I would like, if it's possible, to provide a little bit more important background information about our organization. The National Black Caucus of State Legislators, or NBSL, is the nation's largest organization representing Black elected lawmakers who serves as the voices of the more than 45 million Black people living in the United States today. Okay. NBSL, we unite these voices. Right? We're united voices, and I'm honored to speak on behalf of our elected officials and communities. Is my audio coming in okay? I hear a little background. Am I good? Perfect. All right. Today is the first Friday of Black History Month. Okay, a time in which our nation recognizes the accomplishments of Black people. For many, this is a time of celebration as we reflect upon the progress that we have made since our nation's inception. For others, it's a time of sadness as we lament the labors and lives lost to get this far and how far we still have to go. Today, I sit somewhere in between. Okay, I celebrate our collective consciousness that all people deserve life, liberty, and the pursuit of happiness. This famous phrase from our Declaration of Independence. I celebrate this today because in 1776, the year in which Congress ratified the Declaration of Independence, Black people were not included. We were enslaved. Slavery was not abolished until 1865, nearly 100 years later. With this history in mind, I celebrate our moral victory that today we unanimously agree that all people, including Black people, deserve life, liberty, and a pursuit of happiness. Unfortunately, for Black Americans, the pursuit of life, liberty, and happiness often includes continuous access to medicine. I use the term, unfortunately, not to disparage medicine or the medical field. Rather, I use the term, unfortunately, to describe how social determinants of health, the conditions in which we live, learn, and work, and structural racism causes harm, generational harm, which puts us, our children, and our grandchildren at an increased risk of maladies which require medication. Obesity, hypertension, cardiovascular disease, type 2 diabetes, major depressive disorder. Black people experience an increased risk of sickness and debilitation from all these conditions, as well as others. Evidence indicates that the ills of society contribute to our illness. Simply being Black is a risk factor for disease, and being a Black woman is a risk factor for death. A recent publication from Dr. Elizabeth Halfel states that nationwide, Black women are 3 to 4 times more likely to die from pregnancy-related causes compared to white women. However, in some cities, Black women are 12 times more likely to die. 12 times more likely to die. Being a Black man is also a risk factor for death. Current data from the National Center for Health Statistics demonstrates that the life expectancy of a Black man is 6 years later compared to that of a white man. A separate analysis on police-involved shootings found that Black men are 21 times more likely to be shot dead by police compared to white men. Of particular note, this analysis excludes non-shooting deaths, including those of George Floyd, Eric Garner, Malice Green, and countless other Black men who die during interactions with law enforcement. Now, few could argue that medicine alone could cure the consequences of our nation's greatest sin, slavery, and a tidal wave of economic disadvantage and racism that still cascades through our society today. However, few could argue that Black people should continue to be subject to policies and practices which put us at an even higher risk of disadvantage, disease, and death. This is why NBSL is here today. We're here to protect the health and well-being of Black people. At our annual legislative conference in December of just this past year, we passed a resolution stating that prescription drug advisory boards should work to ensure that prescription medications remain available to patients, and prescription drug advisory boards should not create greater disparities in health or healthcare. This year, we plan to submit our resolution to the President and Vice President of the United States, members of Congress, and other federal and state government officials as appropriate. Now, to the direct question of can a focus on health equity and state prescription drug affordability boards coexist, or are there inherent unresolvable conflicts? Well, based on the language within our resolution, we believe that they can. I'll say it again. Our resolution states that PDABs should work to ensure that prescription medications remain available to patients, and they should not create greater health disparities in health or health care. That's health equity.
Thank you, Dr. Banks. I want to follow up a bit with the opening remarks from the panelists before we turn to the audience questions. And for those who may not know, the mission of the National Minority Quality Forum is to reduce patient risk by ensuring quality care for all. And our vision is a research delivery and financing system that assigns a higher valence to patient risk reduction than to financial risk mitigation. It is not that we don't recognize that that financing is an essential component of a healthy research delivery and financing system. But what we have seen over the decades is efforts that are designed as patient risk reduction, but are actual financial risk mitigation. And in our view, the PDAB movement is at risk and possibly designed to fall into that same category. And so I'm reacting to the comment from Mr. Laws when he said, well, they're well-intentioned, but may not be designed to accomplish that goal. I'm not entirely sure they're well-intentioned through the lens of patient risk reduction. And I think what we're seeing and we're beginning to see in terms of the remarks from the audience is opening the door to that broader conversation and to the remarks that Dr. Banks made, which is that my rephrasing of his remarks, we must pursue efforts to assure that PDABs are improving access to therapies rather than constraining that access in the interest of financial risk mitigation. And I would say it's a particular concern for NMQF because just as we're seeing leaps forward in terms of the ability of science, the ability of technology to be more precise in terms of its responsiveness to different biomarkers, we're seeing what may be predictable but potentially problematic, a resistance to the financial challenges, addressing the financial challenges associated with creating that broader denominator of citizens who have the potential to be positively affected by our scientific advances. And then that denominator, which is those who actually respond positively. A particular concern being that constraining access to certain therapies by definition restricts access of the information that your body brings to the conversation, to research, to diagnosis and treatment guidelines, or to payment. So I'm saying a lot here that, but I'm I'm going to assume that I am reacting, or let's say I'm reacting to the comments from the panelists, not just as the moderator, but as a member of this health policy community that is desirous of assuring that the potential of our science is indeed always forward-looking and accessible to all of us. The presumption that there's just not enough money to go around, I think, is not a platform on which we need to build our strategies. How we use the legitimate concerns of the different business sectors that are part of this conversation continues to be addressed in policy circles, with PDAB being the most recent. And I guess I'm encouraging our audience as well as our panelists to help us think forward to a research delivery and financing system that maybe is designed upon different principles, not based upon an assumption that there's not enough to go around, but what we put in place as an infrastructure that enables that which is available to broaden the market, to share across all population cohorts, and to broaden the market in a way that serves the best interests of all sectors. So that was going to be a short remark. It turned into to be a longer remark, but I think we do have some, I don't know if any of the panelists want to react to anything I've just said.
There's no reaction, Ms. Ford, but if I can try to provide, well, I'll kind of blend a reaction with the response to one of the questions here I see within the chat. I'm not sure if everyone can see this, so if it's okay if I can read just the Q&A here from one of the individuals. It states, in Illinois, AARP is championing the PDAB legislation introduced here. Why are they so supportive when it is clear this legislation would actually be more of a detriment to seniors? If I can answer that, I think it starts with actually reading the model legislation, right? Because of the idea of, affordability in healthcare, that's something we can all get behind, right? That's of course we want healthcare to, be affordable. And so that's being what we see as legislation being promulgated under that umbrella without reading the fine print, right? How many of you try to get out of a contract, whether it be a cell phone or a provider, you read the fine print, right? There's something in there. So encourage you to read the fine print. And so what some of the model legislation that we've looked at, that's just really encourage you to look at that. And Gretchen, I think the path forward, we have to move forward together, right? Moving forward together. And I'll just read some language from the model legislation. I don't know if we can put links to that after in the chat or after the webinar here, but it is divisive, right? We have to move forward together in order to achieve health equity. Healthcare has to be a partner. We cannot frame healthcare as an enemy of health equity. We're moving forward together. I quoted the statistics on the maternal disparities amongst Black women. That's healthcare. If we're going to reduce that, we have to be in alignment. We have to, frame healthcare as an ally. They're an essential ally if we're going to achieve health equity. Period. But when we look at some of this language here, as far as the composition of these advisory boards themselves, it strictly prohibits the involvement of healthcare. It's particularly, you look at the language, no board member may be an employee of a manufacturer, pharmacy, a health plan, pharmacy. It really discludes healthcare, in which is problematic when you start to look at the fine print, the nuances. We see that a lot of these health plans, virtually all the major ones over the past several years, have hired what we call chief health equity officers, or CHEOs. These are individuals who are tasked specifically to promote health equity, reduce health disparities, and promote health equity within the health plans, Medicaid specifically. So if we have language, model legislation, right, that is actually, kicking these people off the table, you're not even considered, then that is inherently divisive. We're not moving forward together. So that's just one example. And I would just encourage anyone to look at that specific legislation, the model legislation, the legislation that's being promulgated within your state, to actually read the fine print. All right. And so I know that was a little worded, but so I'll stop there. But just, read the fine print, just like with the cell phone.
I wanted to
Yeah,
hop onto that
you.
exact point because I saw that comment as well, and I think it was directed in my direction. Because we do a lot of we do work with ARP in many different cases, but I think exactly to your point, Dr. Banks, it's so important to understand what the legislation is actually saying, and then to also recognize, you know, political cycles. Everything is about what do we do in political cycles, and for the short term, you're absolutely right. If more drugs more affordable for all of us in the short term, who can be against that? But then we look at what the actual long-term impacts of this this legislation could be. That is where the challenge is. So thank you so much for very clearly sort of stating that as well, because we have to look at it as a whole and not just what the initial headline says.
I'd like to springboard real quick, and I think I can move from where we were at to addressing the first question in the Q&A. And I think what we've got to look at here is that the only tool that these PDABs have been provided in terms of addressing any of this financing concern is an upper payment limit or an upper reimbursement limit. They're not being encouraged to explore other tools like group purchasing through different state programs, or how to make investments into issues of health equity and access. They're only being told to how do we take money out of this system, for lack of a better term. And we know that when we take money out of systems, the first people to be hurt are the folks least represented, right? There's no two ways about that. And as we consider what that means in terms of access, especially for marginalized populations, I think it gets really iffy. There's a reason that there's no quality metrics on this. There's a reason that there's no monitoring metrics on this. It's a smash and grab operation. And that's, I don't mean to be aggressive about it, but that's when my healthcare is on the line, I get to have some feels about it, right? So when we're talking about that reduction in reimbursement rate, and this goes to the 340B question, is it's not going to change your purchase price in 340B, but it will reduce your rebate value that comes back from it, because that reimbursement rate is limited lower. And we're already seeing this in some of the IRA stuff specific to the $35 insulin cap. For folks unfamiliar, FQHCs made some money off, and safety net hospitals were able to kind of get a rebate structure back with certain insulins, ranging anywhere between $300 and $500. And those insulins made about 10% of their rebate structure. They were able to reinvest those dollars into providing free, reduced cost medication, reduced cost care, things like that, that for these populations are communities that really wouldn't have access otherwise. And what's happened is that those dollars, or those rebate dollars, have now reduced to about $8 per prescription fill. And this would have a similar effect. You're talking about losing almost 10% of your rebate dollars in FQHCs. And so there's a question in the chat that says, hey, is there any way to exempt FQHCs from this piece? No, these reimbursement limits are system-wide. You can't carve out a particular provider on that reimbursement limit. Some of these pieces of legislation do say that you can't have discriminatory reimbursement, but you're still lowering that cap and reducing the investment in system that is really designed to address health equity concerns and health disparities. So we know this is going to hurt us. We know it, and yet it's still, we're hearing this word affordability, and it's being sold as patient affordability, but really that's not what's happening here. We're not talking from patient perspective. And I think part of addressing this is going to be going from that patient perspective, coming from the communities that need the most help, and saying, what are our actual answers, not just this one thing that doesn't work. So I apologize for the length of that.
No, but please do. And I would say that if Dr. Puckman were here, his reaction to your concern about being aggressive would be, by all means, we must be aggressive, constructively so, but we must be aggressive and focused, because this is an assault on our ability not just to obtain health care, but to sustain our lives, not just our health in the moment, but also the fact of our lives. So a strong response is warranted. A structured, coordinated response is absolutely essential so that we're not, so that the response is not fragmented. I would say that there are some questions in the Q&A regarding are there other organizations who support PDABs in different states? And I think that's it's not only their right, I think it's also a function of the degree to which the nature of the impact of these PDABs on the health of populations is masked by the lexicon that they use. And so being very clear about where that affordability is manifest and how it can or cannot, whatever the cost savings are, how those cost savings can or cannot be funneled into a system that broadens access, that encourages innovation by enabling access to the therapies that result from the innovative research. So by all means, you should be passionate about this, and what we're hoping to pull through or instill in our audience is passionate engagement on this issue, regardless of where you fall. Making sure we're all clear on what's really happening here is essential. Where are we? We've got a few more minutes.
There's a question, Ms. Wartman, if possible. I mean, some of the language is nuanced, but there's just a very simple, straightforward one from an attendee. How are these advisory boards chosen? And how do they define what's affordable?
Yeah.
That was $1 billion question. I would like to answer that just following up on my co-presenters here. Based on a model legislation, again, you have to read the specific legislation within your state. But the model legislation, that these are appointed positions, right? They're not, elected, they're appointed by the governor. And I say that because as a Black male individual, are they representative of the leadership in your state, right? Do we look like your governor? All right. You can also look at, for looking at Medicaid, state Medicaid directors. Melissa mentioned earlier, this has been around for 60 years. You can just Google search right now, state Medicaid directors, and see if you find a Black man, an Asian woman, a transgender individual today or in the history of it. 60 years across every state. All right. And I'll answer that question that way. So that gives us pause within the National Black Caucus. It's flat out frightening of who's going to be on these boards determining what medications are too expensive for Black people to access.
Well, and I think that really kind of points to the issue of not having patient appointment to these boards and patient focus. Dr. Banks, I think that really speaks very, very directly to our foremost concern is you're never going to have a policy solution that meets patient needs if patients aren't leading that. In HIV, we have nothing about us without us, right? Like that's a huge stump piece, in part because of how much HIV impacts marginalized communities. So 100%. And thank you.
And I think that's why we're at this critical moment. I think they're great questions in the Q&A too about, how do we get together on our messaging of this, understanding that there are certainly those who are in favor of PDABs who have very strong voices. And I do think it's forums like this to make sure we're educated and making sure that we are aligning the people within the states where we need to be, who are having PDABs first, Maryland, Virginia, Oregon, others, Illinois, to make sure that we are on the same page. And I think NMQF is a great facilitator, again, of these conversations and to understand how we can go about that together with some common messages around the impact on underserved communities, the impact on the Black community, the impact on HIV population, the impact on the transgender community, on an aging population. And we would love to help spell all that out so that everyone here can get, all the information they need so that they can go to their legislatures to have all of that information. And I think to what you were saying, Dr. Banks, about kind of healthcare being involved in the conversation, right? Because PDAB is something very specific to what we're looking at in terms of prescription drugs. When we think about overall access to healthcare and the impact on communities that are underserved because they're in a rural community and they're far away from their healthcare providers, because they simply don't have access because of cost concerns, they don't understand how Medicaid works, or simply because they don't trust healthcare providers for the many reasons that are perfectly reasonable for not trusting healthcare providers that have happened in the past. We want to change that. One of the things that we're looking at too, and that we're working on, is in communities where there is a stark life expectancy disparity. For instance, we have a program going on in Baltimore right now where there's a 20-year difference in life expectancy from a primarily Black community and a primarily white community that's basically across the street. That should not happen in the United States of America. And so how do we make sure that we are leveraging the communities and the places where people come, meeting them where they are, so they all understand what is at stake if we don't get these healthcare challenges, if we don't start talking about these healthcare challenges, talking about the overall impacts. And so PDABs gives us a really good place to kind of center some of these discussions, but it is a broader discussion about the overall healthcare system and how we're not reaching our underserved communities in the right way and how we need to be doing more of that together.
Right. I think that's excellent. We've already started actually addressing the last question, and so I'm going to officially put it on the table, which is recognizing what may be the reality of these state PDABs for the foreseeable future. What function or priority would you mandate to center equity in PDAB structures and processes? And I would add to that, how do you recommend that we move forward in a collaborative way to influence this movement to the extent we can, to assure that it is pro-population, pro-patient, and not singly focused, for instance, on the financial risk mitigation. I will, speaking on behalf of the National Minority Equality Forum, state that one of the some of the work we're going to do is to create the capacity to monitor in real time activity in the different states and how it varies among states. I mean, some of it can get down into the weeds, but to create a single source of information on PDABs. But I would also say, or remind those who may not know, that we also have the ability to link policy with statistics on prevalence and trends in certain disease states. And using the technology we have, that the private cloud that we have developed, that opens the door for analysis across both quantitative and qualitative data, to assure that we can get a more complete picture of what's occurring in the states and where the pressure points may be to engage in states with certain models is where NMQF is. But I will also then open that to the panel for your reaction to, once again, a fairly long question from me.
Gretchen, if I may, I would just like to follow up on something that Melissa stated. As a proud graduate of the Johns Hopkins Bloomberg School of Public Health right there in Baltimore, I saw many of these factors which contribute to the disparities, which she mentioned firsthand. All right, and that just really ties into my previous point. We see it's there needs to be inclusion. We need to have the community at the table. We need to have representation. We need to have individuals who look and represent like myself, Melissa, Jen, yourself, including healthcare. We need to all be at the table. It can't be an us versus them. We all need to be there and hear these important perspectives. We may disagree on certain things, which is fine, but that sort of collaboration is essential. If we're going to move towards health equity, we have to move there together, and without trying to pigeonhole or trying to vilify in the individuals. And you have to be honest about these things, right? When I start to see legislation being promulgated on the root causes of, promoting, reducing racism and promoting equity, I mean, just right there in Baltimore, a lot of things had little to do with medicine, had to do with, social and structural determinants of health, racism, lack of opportunity, lack of, their, involvement. And so it's, let's just be, real and honest and move forward better together.
And Dr. Banks, I'd love to talk to you about the program that we have going on there, because it is about making sure that when you're doing things for the community, you're doing them with the community. We can't, exactly what we're saying about who's on these PDAB boards. If you don't have the community involved, you don't ask the community what they need, you don't ask individuals what are their real challenges, right? So they're thinking about filling a prescription. Well, they're trying to think about how to get food for their family for the week, and what do they choose? And so this is where, again, fundamental conversation of how we bring it together. And then I think, Gretchen, going back to your point, I think ties in here, how do we get aligned and working together? I love what you're doing. I think we're going to have continual monitoring this, because there'll be many balls up in the air that we're going to be juggling and trying to monitor what's going on in each of the individual states. And hopefully we'll be able to take lessons from the states as we move through this process. But, if we can center ourselves on the policy principles that, can help us understand what are our arguments, and are they real? What do they mean for individuals who are impacted by this? And, we worked on a set of policy principles in terms of how do we continue to promote innovation, new medicines, with that lens towards making sure people have the ability to age as healthy as possible for as long as possible. And it really does start with first keeping that individual, the person, at the center of any discussions of healthcare innovations. And it's also about looking at, we can say patients, but many times we say it's the individuals, it's the people, because many times they're preventive medicines. They're a patient at one time, but they're on a medication to prevent them from being a patient, quote unquote, again. So these are the people we want to keep at the center. Keeping people healthy keeps them active, keeps them productive. And that is our goal. And so when we think about how we sufficiently value and incentivize, because I think it's the second thing that's really important, how we value and incentivize medical innovations, they're investments. We have to look at them as investments. We have to do the analysis that show what is that long-term return on investment going to be. And so a lot of times the conversation is about it's a cost and we can't do it. We can't do it. We're going to cost savings time. We can't do it. But when you look at what the overall investment is and what the benefits are at the end of it, this can be about the individuals, but it can also be positive in terms of cost mitigation as well. We just have to look out in the future. And then I think the important thing too that we've been talking about here is on process innovation. Any innovations that come, whether it's medical innovation or technical innovation, we've seen it in technology, in digital health. How you implement, is critical. How you can have all the great innovations in the world, but if we don't know how to put them into a system and ensure people know how to use them, why are they here? And so I think we have a very important role to play as well, to recognize that, yes, the innovations are there, and if they feel like they're out of reach, we have to figure out a way to make those realities for the people who need them most. And it certainly does, going back to the point, it involves the health system, the entire health system, and this ecosystem, which is so critical for how we change the trajectory of health in the United States.
Thank you. Oh, go ahead.
I wanted to point out, and this is something that's always really hard when it comes to activating a local community and everything else, is there is no law on the books that cannot be repealed or modified, that cannot be changed. There is nothing that stops community engagement from having that meaningful impact, especially when we're leading with patient voices on issues of healthcare, especially when we're leading with community voices when it comes to issues of health equity, right? So when these boards are established, there are public comment periods, but I'm going to be honest, with our experience in Colorado, they don't listen, they don't care. the space where that happens, we saw it in New Mexico when they did an exploratory committee, is when you have that patient voice on the board, right? So if you're in a state where it looks like this is predetermined, it's going to happen this way, anything else, your opportunity is to go, okay, make sure there's patient voice on the board. You need to amend this model legislation to make sure that patients are leading. You need to amend this model legislation to make sure there's pass-through revenue savings, and you need to amend this model legislation to make sure that there's a monitoring on who this is impacting and how, because we deserve to have somebody actually care better than a cheap sales point. When we talk about savings, it's really important to ask, savings for who?
Well, and thank you for that, and reminding us that absent the ability to change laws that are on the books, none of us would be here on this panel today. So remembering that we always have not only the right, but perhaps the responsibility to look at these issues through the lens of all patient cohorts, and ensuring that we're continuing to monitor the state of play to assure that as additional information becomes available, as biomarker knowledge expands, so that we all actually not become just a member of the greater population, but all very specifically, to some degree, our own rare life form. And we have the ability with our science to be responsive to that. But we do have to continue to be conscious of those whose business models are in conflict with that, and make sure that we not turn a blind eye to that, but find a way to constructively engage. So I'm going to, we're moving towards the end. All of the information that has been shared in the chat, I think it is, as well as additional information as it becomes available, we will post on our Center for Public Policy website. So that several questions were asked regarding who's monitoring what's happening in the states. How do I find out what's going on? Every entity that has exposure is monitoring what's happening, but not necessarily through the broader population lens. And that's where the National Minority Quality Forum's data and research capabilities can come into play. I will also then, unless there are other comments from the panelists, thank you all for such an engaged conversation. I have 3 new colleagues, and I had not met you prior to yesterday, and thank you so much for your engagement on this issue. I also want to thank the audience for registering, those who listened, and encourage all of you to communicate either with the individual panelists, if their information is available, or to contact me. And I think Ashley can put my email address into the chat, and so that we don't lose what I'm concerned is a really significant battle to make sure that our, and I will always say it this way, research delivery and financing system is opening its doors to those of us who have been excluded, not simply protecting themselves from our engagement. So thank you all. Thanks for a wonderful webinar, and enjoy the rest of your day.